Good morning, good afternoon, good evening, good night, maybe wherever you are. I don't see detail of the attendees for this, but I think it's mostly from here in Asia and Europe, so not been very late night. Thank you very much for joining this global solution. Global Solution Summit is organizing several discussion on various issues in G20. The main topic at this time to ensuring well-being for everyone, and for the well-being, we are picking one aspect which is related to universal health coverage, and also covering a special innovative medicine. While as we know that the global leaders, the world leaders already signed the Sustained Development Goal, SDG. If we look at the SDG 3.8, it is universal health coverage, and one indicator of the universal health coverage, indicator 3.8.2, is the health spending as proportion of income of the household as a measure of catastrophic health spending. Certainly, universal health coverage aims at minimizing catastrophic health spending in many countries that are engaged with mostly in low middle income countries. Often the universal health coverage cover only relatively low cost medicine or intervention, even some limited. Certainly private sector also provide limitation on coverage. They put ceiling or maximum coverage and so on, while for people who are suffering from cancer and from some other non-communicable disease, which is the medicine now with the high technology, thanks God for this innovation, research on the pharmacies and medical technology, we provide now in the world medicines, innovative medicine. However, studies to find innovative medicine costly, and certainly the industries have the right to set some price because of the intellectual property right to return the investment, and that's become a burden for many developing countries. If the system could not afford, then the people will not get the well-being as we are discussing this issue at this time. How do we find a solution for that? Hopefully, we can find some solution, and we can write some concept notes that in the end, from us, I'm the lead co-chair of the T20 Indonesia. We are looking at some solution on this issue that we will hand in to our president, the presidency of G20 this year in Indonesia. The meeting of the summit of G20 will be held in Bali in November. Next year will be in India. So Dr. Monica might also prepare for that in India next year. Certainly this is a big issue, but as I believe that the world can do better if we organize, we talk, we discuss, and we find solution. In Indonesia, we try to improve access to this expensive medical technology, including innovative medicine, by mobilizing resources through the National Health Insurance Scheme. Later, Dr. Al-Fazil will discuss that. But still, we are facing some problem in meeting the need of the people and improving well-being of the patient with cancer especially, and other non-communicable disease. So this is the session that we are going to discuss this issue. Just as introduction, I would like also to for our audience, which is now about 60, thanks God, to introduce our team, our panelists here. I can start with the ladies first. Yeah, from Samantha, maybe introduce yourself, please.
Okay. Good afternoon, everyone. Greetings from Jakarta to everyone in Berlin, Lucerne, India, and of course, around Jakarta. Thank you for having me. Thank you, Professor Hasbullah, for giving me as a survivor, also as a patient group, to be invited in this special event. Thank you for all the committee and also the Indonesian Health Economics Association team. Thank you so much, and greetings to fabulous speakers, Dr. Al-Fazir, Dr. Monica, Mr. Thomas Jacobs, and also Dr. Amit Kumar. Thank you for having me.
Thank you, Samantha. And then go to the next lady, Dr. Monica. Please introduce yourself. Yeah.
Good morning, good afternoon, and good evening, everyone. Hi, I am Monica. I'm a medical doctor by training and a public health specialist, currently working as a global policy lead at Hoffmann La Roche, Switzerland, Basel. And I'm here to represent the private sector perspective on, equitable access for cancer care and innovative medicines. And very happy and pleased to be part of this panel and look forward to our discussion today. Thank you.
Thank you, Marika. And then Thomas.
Yes, hi everybody. So I'm Thomas Jacobs. I'm a Global Market Access Director at MSD, Merck Sharp and Dohme. And I would like to thank you all for the invitation, and I'm really looking forward for the good discussion. Thank you.
Thank you. And then Dr. Ahmad Al-Fazir.
Hello, everyone. Good morning, good afternoon, good evening. My name is Al-Fazir. I'm from Ministry of Health, Republic of Indonesia, Head of Health Financing Policy Task Force and Young Expert Policy. And then I represent Ministry of Health to discuss about the inequity access through innovative financing in Indonesia. Thank you.
Thank you very much. Also, thanks to our team in Indonesia. This discussion is hosted by the Center for Health Policy and Management of Universitas Indonesia, is public universities, and the Indonesian Health Economic Association in collaboration with Global Solutions Initiative. Thank you. First, I would like to maybe discuss the issue that I told you about this access to innovative medicine. Can I start with the patient group first? Yeah, so then we know how how the situation. Sorry, I think I just mix it that to make more live. Yeah, Ibu Samantha, what the experience of cancer survivor, cancer patient in accessing adequate cancer medication in Indonesia? You have a lot of members. How do you assist them? Do your members receive adequate coverage from our national health insurance?
Okay, thank you for the time, Professor Hasbullah. Before I share my experience, I think I will a little bit introduce my background and also foundation that I lead. I was diagnosed in 2013 with HER2 positive stadium 2B. As usual, had mastectomy, radical chemo, radiation, and also targeted therapy. So this year I am on my 9 years remission. So it's a blessing, and life after cancer, it's real. Yeah, so I'm a survivor and also a chairwoman of Daya Dara Indonesia Foundation, or LovePing. This is a breast cancer community, a platform to empower the warriors and survivors. Our main mission is to educate and to support moral for the patients and family. So we promote awareness, early detection. We promote access to education, education materials in terms of flyers, movie. We are heavy in social media. We have apps. It's a Breasties apps and also online empowerment Ping Talk. At the same time, we do give access to screening and free ultrasound to underprivileged women since 2015. And right now we have 7 chapters around Indonesia. Some of them are outside Java. And this is when the challenge, I think, happened. Before accessing the medication, I think we have a gap of distant to medical centers. It's the differences between urban and rural areas. So it's a challenging geographical inequities for Indonesia. We have 17,000 islands, so it's not easy to have medical centers in every corner of the islands. So as a result, many of our patients, they go to herbal treatment first, or since the medication is very expensive, they live their life living with pain with breast cancer, thus increasing the mortality rate of the patient. And I think I have to raise the gap of waiting time. Lack of a lab result, and also doctors, oncologists, pathologists. Treatment in timely manner is very crucial for cancer, but with so many times delay, this is can lead a very critical and also worse situation. Lab result delay, follow-up consultation delay, doctors cannot properly suggest a timely and complete diagnosis or treatments. Plus, these past 2 years, the fear of COVID play a big role. So some of the patients are hesitated to go to the hospital. Now, your question about the gap to access medication. From my patient's experience, I think before that, we are so pleased that the government of Indonesia has introduced national health insurance, the JKN, which managed by BPJS, in order to provide easy access to health services to the entire population. Which of course focus on targeting and subsidizing care for the poor. However, not all the cancer medication is covered. For example, I'm a HER2 positive patient. I know my prognosis. I was treated with this targeted therapy in early stage. Of course, before it spread to my other body parts. And I am so lucky because it provides me with the best chance of cure. As mentioned earlier, I'm on my 9 years remission now. But this particular trastuzumab, the targeted therapy for HER2 positive, it is only now dedicated, cover 8 times for those patients in stage 4, in a very complex and metastasis condition. So what about my other early stage patients? LovePing, the foundations is trying so hard to promote early detection in order to lower and help the government to lower the number of advanced breast cancer. So how we possibly save these patients? I believe it's kindly unethical to promote prevention, early detection, but you leave behind the patient with HER2 positive in early stage breast cancer without getting the meds there that they need. I think that's some of the gap, Professor, that I can share with you.
Thank you, Samantha. I think that it just give us some illustration. Dr. Al-Fazir, tell us a little bit about what the Ministry of Health making. I understand that the Ministry of Health has the Health Technology Assessment Commission to balance between the availability of resources and the need for some expensive medication to ensure that balancing between resource limited and also demand or the need for the healthcare. What do the Ministry or the government of Indonesia doing?
Okay, thank you, Prof. As we all know, Indonesia has implemented JKN or National Insurance for 8 years, and it is many challenging and facing many experience to give all the citizens a better health services. And then if we talk about the JKN, there are several policy instruments which is assist in optimizing health financing scheme. I think we already have the track program progress, and then we already explore about the PPP, public-private partnership to cover the gap, to cover the lag. And then as you mentioned, to answer the cost effectiveness of program cover under JKN, we already have health technology assessment was conducted regularly by the involving various stakeholders in health sector, and then it is leadership by the Ministry of Health. Innovative financing scheme depends on the coverage of innovative yet affordable health modality. Effectiveness become important as there are fast option for a modality. However, affordability of such technology become trade-off. Particularly, there is a constraint related to public budget use. And then if we talk about the HTA for medicine, health procedure, and medical devices that are fastly growing, it's an effort to quality and cost control the implementation of next generation insurance. STA based on real world evidence ensure effective implementation and expansion of use of innovative health modality through public financing scheme. As we know that through economic evaluation, HTA implemented direct comparison of new technology, and then coupled with budget impact, affordability can be measured particularly through the few simulation based on the different scenario. STA also support research and innovation of technology like a medicine, health procedure, medical devices to stimulate the development of the better health outcome. But we have many challenging, many facing to implement the HTA in Indonesia, especially to what if we already release the use of HTA to implement it for the better policy. It's maybe it's quite challenging, Prof. In Ministry of Health, from the committee of HTA already struggle to push the result of the HTA to implement it in the policy of the medicine in JKN and so on. Maybe that's all, Prof.
Yeah.
I can get the explanation.
Yeah, thank you very much. So, Dr. Monica, after this, I would like to hear from Thomas. Dr. Monica, as public health expert, and you are working with the Roche and pharma company, certainly you are facing both situations. You know that the people need it, and you know how the industry should also doing the best for the industry standard. What is your perspective on this? And if you have some experience also from India, how Indian government also tackle this situation, please share with us. Thank you.
Sure. Thank you, Professor. And first of all, thank you, Samantha, for sharing story. And it's heartening to see that trastuzumab, which is one of Roche drugs, was a lifesaver and a life-changing agent in your life. So thank you so much for sharing your story. It makes me believe that we're doing good job in Roche as well, saving many more lives. In terms of today's discussion, I would like to bring to our notice again, like we all know that 2 years after the first identification of COVID-19, how much the pandemic has disrupted our lives. And now in the midst of it, there is an urgent need to ensure that people with non-communicable diseases, especially cancer, are not forgotten. And we as a society do not fall into the trap of swapping one health crisis for another. And this is not an easy task. And Samantha has already mentioned that there are a lot of reasons why cancer patients do not have access to the care they need. And there are multiple barriers across the patient journey. Let me take example of Indonesia here, where cancer is the 4th leading cause of death, according to WHO, with nearly 397,000 people diagnosed with cancer in 2020. With significant regional disparities, ensuring access to high quality healthcare across Indonesia is proving to be a challenge. And more so because as the world's largest archipelagic country, Indonesia has over 17,000 islands and 270 million inhabitants. And this poses significant challenges to providing cancer care throughout the country, especially considering the lack of trained oncologists and the large gap in their availability throughout the different regions of Indonesia. And this is actually a situation of many other low or middle income countries, including India, where more action is needed to address the cancer care gap. But beyond healthcare systems challenges, we have also understood that current traditional funding models still struggle to close this gap. And a key challenge within this funding gap is related to limited access to standards of care. So affordability is in fact a significant barrier to receiving treatment, including for cancer. But to address this challenge, we need innovative funding models, and alone they are not sufficient to address the growing burden of cancer and the high cost of NCD, so to say. So in today's pandemic context, inequalities or barriers to accessing the best care are more likely to worsen. And what should we think of true pandemic preparedness? Because it should mean that we should be able to expand and ensure universal health coverage to help prevent healthcare systems disruptions. Healthcare systems must be built to ensure the effective management of outbreak-related issues without compromising on the services for the prevention, diagnosis, and treatment of any other health issue at the same time. And this is why promoting improved access to our technologies and engaging in cross-sector partnerships, while we do that, we are also supporting the global effort towards universal health coverage. And it is also why we prioritize supporting the building of resilient healthcare systems and recognize how national pandemic preparedness plans play an essential role in countries' sustainable development. Cancer is only one condition targeted by high-cost innovative treatments that are increasing. UHC sets amongst the priorities that need to cover the necessary intervention. And it is also important to understand that challenges around cancer care are many, and investment is necessary in all aspects of it. And now talking about the private sector's role, and as a representative of the biopharma industry, I want to tell you that we are working hard to support access for many years, addressing these key barriers. And at Roche, we've been proactively looking at what we can do to expedite access to innovative medicines. We've taken a responsible approach to pricing in line with WHO definition of fair pricing. And in order to achieve broad and equitable access, we are applying an international differential pricing strategy to address the needs and to improve affordability across all countries. And the price of the medicine therefore varies from country to country based on country's ability to pay. But like I said, beyond innovative pricing approach, we need to, and we are working towards increasing healthcare access for patients to improve their treatment, especially in countries like Colombia and Saudi Arabia, and also collaborating with insurance partners to promote wider coverage for cancer patients in China and in Italy as well. So like I said, to build back better beyond the pandemic, investing in more resilient health systems will be the key. And just to sum up, and also mentioning a bit from India as well, as we all know, like Indonesia, India also rolled out its biggest national insurance scheme in 2018 called the Ayushman Bharat scheme, has also integrated many aspects of cancer care and has actually set up a cancer virtual board to ensure that, it should be able to cover the treatment for the patients in the limited, cap that they've put for the scheme. To sum up, like I said, the global health architecture, including the private sector, has faced serious challenges and been forced to adapt as a result of pandemic. And we have transformed the course of pandemic through the speed of development, like, as you've seen in the case of vaccines as well, production going from 0 to 11.2 billion doses in less than a year. So we've achieved so much together through these challenges, and we must continue to keep working together to ensure that governance and financial mechanisms for healthcare systems are resilient, robust, and better able to ensure health for all. Thank you.
Thank you, Dr. Monica. Yeah, most of the developing countries spend only about 3% of the GDP in the public financing for healthcare, while in the developed country, the proportion reaching 8 to 11%. Certainly, it's a big gap with that. But solution is there, and thanks the private sector also thinking about that. Then I can go to Thomas. What are option and best practice there that industry will also do something to ensure, other than just public-private financing, balancing, and so on? There are a lot of innovation today. Can you tell us, Thomas?
Yes, thank you, Professor Hasbullah, and thank you, Samantha, for sharing your story, and Dr. Aflazir for providing the point of view of the Ministry of Health. So, I would like to start by acknowledging the progress done over the last 10 years in Indonesia in terms of increasing access. So we mentioned the JKN, it covers now 84% of the population. And I also would like to mention the Coordination of Benefits Initiative, the COB, that is really opening the way to top up insurance. There are also apps like Penduli Lindugi. And so all these efforts are really creating a fertile ground for innovative financing. However, there is an opportunity for improvement, especially around NCDs coverage, so non-communicable disease. With the increasing healthcare costs, with the growing burden of NCDs, more and more people are suffering from NCDs. All of this is really jeopardizing the sustainability of universal healthcare, and which is already weakened by the COVID-19 pandemic. So, however, I think there is hope and there is an opportunity, and the pharma industry can definitely play a major role here. Of course, there is the obvious scientific contribution from the pharma industry developing innovative treatments, but also specifically on the funding sides, I think that we can play a role. And I would like to highlight one particular mechanism here, which I believe we can help with. It's the top-up private insurance, which is also called SMI, or supplemental medical insurance. So the SMI can provide a basic coverage on cancer care, which could be, for example, partially subsidized by SIMPAX money, And at the same time, we could collaborate with private insurers to offer a more comprehensive package of tailored options for people who need it. Now, the thing is, this kind of innovative financing really require a teamwork between various stakeholders. And here I'd like to mention each of the stakeholder and what their role could be. So I think the government here has a prominent role. So and they can really create the right environment, the right sandbox to test and pilot new solutions. We mentioned the COB, so the coordination of benefits. And this could, for example, be extended to include a coverage of innovative treatment, including innovative cancer drug. I think the role of the government can also be to simplify, demystify, and incentivize these kind of solutions. I think it's important for the population to understand how it works and what it can do for them. But we know that today in Indonesia, we have about 7 to 8% of the population that is covered by an insurance. So we need to achieve scale. And to achieve scale, you need to create awareness. And here I think that third parties like patient associations, but also medical societies can help generating this awareness. And I would like also here to mention the digital ecosystem. I mentioned before apps like Penduli Lindungi, but and Samantha, you mentioned the difficulty to reach some population. Well, I think that the digital ecosystem can really be a big and important leverage here. Because we are talking about an insurance solutions, obviously the insurers will play a key role, that goes without saying. And the pharma industry can also help here by providing the data to these insurers so that they can compute the right policy with the right premium. You know, data is really the raw material for insurer. And we have good quality data about which treatment could be used for which cancer, how long would be the treatment, what is the cost of the treatment, also what is coming in the pipeline. And so all of this can help creating these insurance policies. And we also can play a role on the treatment awareness, health literacy, and also the prevention, which can, of course, avoid many of these costs in the first place. Now, I really believe that there is an opportunity here to put something rapidly in place by having a collaboration between these various stakeholders, and that could be, for example, piloted in a specific province in Indonesia, and the pharma industry is ready to help. MSD can help you with this, and I think we can even envision to showcase something at the G20 later this year. It might not be finished by then, but at least we can show the progress. So I think it's really not here. Innovative financing versus traditional financing. You know, the innovative financing will complement the traditional funding and will fill the gaps. And the government will remain the biggest spender on healthcare. And here the pharma can also help by providing alternative pricing mechanisms. For example, like risk sharing programs, including free goods or confidential rebates. So as you can see, the role of pharma is really multiple. We can help with innovative financing and also with alternative pricing mechanisms.
Well, I can ask some more questions for Dr. Monica and Thomas. Since you are working in the globally, maybe your experience in other developing countries. In addition to that, I would welcome participants, especially from developing countries other than Indonesia, to share your best experience. Yes, as Thomas mentioned, that the government's role is very important, although government itself alone will not be adequate. Private sector should go together. So we are trying in Indonesia with the coordination of benefit or insurance, public insurance, private insurance, mobilizing some private initiative, also negotiating with price. Certainly it is not only one issue and one solution, but together we can go together. What was the experience in other countries that you guys in the industry deal or successfully improve access with their limited funding from the public funding or from the government? Either Monica or Thomas can answer that one, or both of you.
Monica, you wanna start?
Sure. So I will talk a little bit about, the two examples that I had mentioned earlier, where we are actually partner with, private insurers to promote wider coverage for cancer patients. Like in China, we actually teamed up with 10 local insurance companies to help develop additional insurance policies that would include cancer care treatment or the overall treatment and care as well. Again, in Italy, like we have recently entered a collaboration, and even though we think that funding is only a problem of low middle income countries when it comes to cancer care, I mean, even if there are high income countries who are spending a lot of money on the healthcare, it's not necessarily that it is put into the right way and the systems are very efficient. So even in a country like Italy, which is doing great, we have recently entered a collaboration with AXA Partners Italia to include one of our foundation medicine services, which is around precision medicine for the genomic profiling of solid tumors within their health policies. I mean, sometimes it's also about shaping the policy landscape. Like if you look at UAE, Dubai, there are so many expats in that country, but these expats do not have adequate health coverage insurance, and under their insurance, they don't even have cancer care included. So we really worked with the the government, with the private insurers to include that there should be beneficiary packages for these expats who are living in Dubai, but actually suffering from a catastrophic crisis because their healthcare services are not covered under the insurance. So to ensure that there is a way forward, I mean, we also have to sometimes look at regional priorities within a country. There are so many disparities that sometimes you also have to focus on those indigenous populations. So these are a few of the examples specifically on working with private health insurers. But like I said, beyond that, there are systemic challenges around, as Samantha had mentioned, about prevention, early diagnosis, and treatment. That's where, I mean, Roche and I'm sure MST as well has also been part of, this biggest multi-company consortium called Access Accelerated. And within that, 25 companies had stood up to provide prevention, treatment, and other services for NCDs, including cancer. And this has been going on for almost 5 years from now, and it is entering into its third phase, where companies are now supporting governments and local cities as well to ensure there are innovative solutions to provide treatment and care for cancer and other NCDs as well. So Thomas, anything that you would like to add?
Yeah, thank you, Monica. And I think it's really indeed a pharma industry effort. Most of these insurance products will work for any product, regardless of the manufacturer. So you shared really relevant examples. I think China, UAE, we work also with insurers, and we work on two types of insurance. So there are really the private insurance and then the public-private. So in terms of private insurance, I could share the example of what we did in South Africa, or that we are doing in Thailand, for example. But then in terms of public-private, which I think is the biggest opportunity for Indonesia, there is the Chinese example indeed. But there are also other systems that use this, and there are multiple ways of thinking about this collaboration. If I take, for example, what is happening in UAE, there is a fund, and I think it was at the beginning an initiative from Roche with AXA about the BASMA fund. So this is a fund that would help topping the insurance contribution to achieve full treatment costs. You have in China, you have the specialty drug insurance that for a very minimum premium would help focusing on coverage of specific drugs. And here, Samantha, also to your point, we can think about specific insurance packages that would allow access these drugs in early stages as well. So when it comes to the insurance, there are many ways of looking at this. You can have top-ups that are specific for a disease. It can be cancer specific. It can be specific for treatment like immuno-oncology. So there are many ways to think about this. I think the key point is really the collaboration, because one company alone or one stakeholder alone will not be able to achieve this. So it's really insurers, government, health authorities, pharma industries, patient associations, and then really leveraging this digital ecosystem, which I believe is the way to achieve scale, which will be very important for the insurance solution to work in the first place.
Okay, Thomas. I think for Ahmad Al-Fazir, as the president of Indonesia just issued instruction of the president or in press to set up the kind of coordination with private insurance.
Benefit.
This model probably can be a good lesson for Indonesia. But what do you think the timeline for that one? Because currently the Indonesia about 85% of the population are already covered. Still not adequate, not enough. For this, what is the plan by the government? In addition to that, for our resource person, there are two questions in the chat. From Thailand, were asking about the most effective financial model for this innovative medicine, and if you have some sources, article to share, please. If not now, maybe later on we can share to the participant for that. Please, Dr. Ahmad.
Yeah, thank you, Prof. Actually, our minister has directed the implement reform in Indonesia sector called transformation health system, and then this is including the reform of financing transformation, Prof. And then one of the part of the reform is to implement the coordination of benefit as
you're having internet connection problem, I think. Yeah, then I can go with Samantha. What do you think this instruction of president, is it good news for the members? How many percent are your members? By the way, yeah.
Okay, since 8 years ago, only about 25
way to like the gap in the to fulfill.
Yeah, later after this. Yeah. Yes, Ahmad.
Hello.
I think your internet connection is not stable. Oh, go ahead.
Yes.
Go ahead. Yeah.
If you ask about the timeline, I think if as you know, if we already implemented the KDK or the CRIS, maybe 1 year ahead we can implement the COB. But I think the regulation to implement it is already there, and then we can. I think the Ministry of Health come up to push and then to strengthen the structure of the COB in Indonesia. Maybe next year, Prof.
Thank you. Samantha, go ahead. After this, Ritman from India would like to share something also. Go ahead, Samantha.
Okay. Yeah. First of all, this is a very eye-opening conversation. I'm going to first highlight the digital ecosystem that Mr. Thomas Jacob has raised. Currently, we have we know that there is a gap of access, information, and education. And as a patient, we don't have a clear path of patient navigation. So most of the time, we arrive in a blank spot with stress, no money, no information, where to follow up. Therefore, LovePink team, Professor asked how many people that working behind LovePink. So actually, it's only 20 to 25 survivors. We are moved. We are can work with only survivors since 8 years ago. So they're doing their social work with love, and we came up with what we called breasties apps. This is it's a 2.0 system for Android only. The 1.0 is Apple and Android, but we don't have money, so we delay the updates because at the beginning we thought people are always on their phone, and the number of smartphone users in Indonesia is estimated to reach 200 million in 2021 only. So it covers about 75%. So this is good. We would like to talk more about this digital ecosystem. Our apps is providing algorithm to alert you to do your breath check. And soon we will activate the forum and a telemedicine consultation. We are working on it. So I think this is a good news for all of us if we can be supported in digital ecosystem.
Thank you, Chamata.
Yeah.
We have only 5 minutes.
Okay,
So
sure.
And Sunny Yusuf Adamu, can you have 1.5 minutes each? Can you share who is going to talk first?
Sure.
Diditman? Yeah.
Hi.
Go ahead.
Thank you for giving me this opportunity. I am from the northeast of India, which is quite endemic to cancer traditionally. And here, cancer care, it's nothing different than what has been done. But it's been steered by the public-private partnership models. And they have also encouraged good quality national cancer institutes in the region. I think these centers are also drawing quality staff like oncologists or rehabilitative therapists from all over the country, which are not locally available. So this is also in turn strengthening local capacity, causing local capacity building in the region. As for the PPP model, I think they have targeted specific industrialists who are also known to be development philanthropists. So I think because they targeted such kind of private entities, this has furthered the effectiveness of the program, I feel, because there's a separate level of commitment altogether. However, this is only at the level of tertiary care, but there needs a lot needs to be done to stimulate community awareness processes, which includes primordial or your primary care of disease symptoms, available schemes, centers of care. These things are still ambiguous at this point. I think building the required osmotic equilibrium between supply and demand would be key to reap the optimal outcomes from the initiative that has been taken. Thank you.
Thank you very much. Sunny Yusuf, go ahead. You raise hand. Yeah. Sunny? It's Sunny Yusuf. Are you there? Oh, maybe some problem. So unfortunately, our time is very short. The organizer already told us we have 2 more minutes. If Sunny cannot share, I would like to express our thankful for the discussion, the panelists, Samantha, Dr. Monica, Thomas, Ahmad Al-Fazir, for sharing this. This is just the trigger for our future discussion in the G20 that showing us, demonstrate options are there. Some experience from other developing countries already there. What we need to coordinate, inform, and find best solution. Yeah. Before I close, probably all of our participants could turn on the video. We can, or the organizing committee can take a picture. That would be great if you could. Go ahead, Mutia, can you do it? Or Mbak Eka, yeah.
Yes,
Thank
Prof.
you. Yeah, thank you very much. Hopefully you have your registration, email address, and others. I think the global solution can record, and we will share any progress in the future. Go ahead. Did you take a picture, or should I comment 1, 2, 3? We have 1
yes,
minute.
it's done, Prof. Sorry,
It's
you want
done.
to do it once again with 1, 2, 3, maybe?
Yeah. 1,
1,
2,
2, 3.
3. That's one shot, one screen. You have another screen?
Yeah.
Yeah.
Okay. 1, 2, 3.
Okay.
then-
Maybe another screen. I don't know.
Maybe just another one screen, Prof.
Okay.
Just open your camera. 1, 2, 3. Thank you.
Thank you very much for CHAM, Center for Health Management and Policy, Universitas Indonesia, and Indonesian Health Economic Association to host this discussion together with a Global Solution Initiative in Berlin. Hopefully we can contribute to our world more well-being for everybody. It will be coming. We can do it, but it just takes some time and coordination. Thank you all, our panelists, our participants. Great contribution, and hopefully we can do better always, guys. Thank you. I return to the
Thank you
organizing
so
committee.
much,
Thank you.
everyone.
Thank you.
Anta, thank you,
Thank
Prof.
you.
Thomas, Monica.